Here's the roadmap for our patient's journey today. 1. Assessing surgical nutrition. 2. Caloric needs and enteral feeding. 3. Total parenteral nutrition. 4. Navigating TPN complications. And 5. Post-operative fluid management. Let's get to it.
Section 1. Assessing surgical nutrition, identifying malnutrition risk, and tracking trends. Now, beyond just pulling labs, we really have to look at the patient's history. And here's a classic exam favorite for you. If a patient unintentionally loses more than 10% of their body weight in just 6 months, that is the literal definition of significant weight loss. It's a massive red flag for a poor clinical prognosis. You are going to get asked this on the wards, for sure. So lock that definition in right now. To actually formalize that risk, we use the MUST score. It's an essential 5-step algorithm that takes us from a basic BMI calculation all the way to targeted dietary interventions. You factor in the BMI, the weight loss score, and the acute disease effect score. Tally it all up. A score of 0, low risk, routine care. A 1 means medium risk, so you observe and document. But a 2 or higher, that's high risk. That triggers an immediate referral to a dietitian for specialized team-based care. Oh, and remember, the MUST score is not a one-and-done deal. You have to routinely reassess the patient after your interventions. Actually, scratch that. It's not just a have to, it's absolutely crucial.
Section 2. Caloric needs and enteral feeding. Calculating energy and choosing the gut.
This is where it gets really interesting. Look at how physiological stress just aggressively scales up a patient's caloric demand. We start with the REE, the resting energy expenditure. A normal baseline patient needs, about 20 kilocalories per kilo per day. But watch what happens when you introduce trauma or infection. Mild sepsis, that bumps the multiplier to 1.4. Severe sepsis pushes it to 1.8. And severe burns? A severe burn victim requires literally double that baseline amount. That's 40 kilocalories per kilo per day just to heal those tissues. Wild, right?
So the big debate is, how do we actually deliver those calories? Enteral versus parenteral. Well, enteral nutrition, feeding through the gut, is physiological, it's way cheaper, it maintains enterohepatic circulation to stop cholestasis, and it preserves intestinal microvilli. But crucially, it prevents the translocation of gut bacteria. Think about it. If you don't feed the gut bacteria, they get hungry, leave the gut, and cause systemic infections. No thanks. This makes enteral feeding vastly superior to IV parenteral feeding. Rule of thumb, if the gut works, use it. Okay, so if they need short-term enteral feeding, meaning, let's say, less than 2 to 3 weeks, your choice of tube really depends on the stomach. If gastric emptying is good, you just go with the standard nasogastric or Ryle's tube right into the stomach. But if emptying is poor, you'll usually see this signaled by nausea, vomiting, or constant bloating. In that case, you need a nasojejunal tube to just bypass that sluggish stomach altogether. Let's actually break down the physical steps for inserting a Ryle's tube, because it's a highly tested clinical skill. First, positioning. Get the patient sitting up, neck slightly flexed. Next, the measurement. You don't just eyeball this. You measure from the tip of the nose to the ear lobule, and then from that ear lobule straight down to the xiphistidum. Finally, confirm the placement. You do this by aspirating gastric contents, or if you can't get an aspirate, inject some air with a syringe and auscultate the epigastrium. You should hear a clear whoosh. All right, the tube is in. Now what? Well, there are golden rules here. Never flood the bowel. You want to start slow, like 20 to 30 mils per hour, and build up. Always, always aspirate before giving the next feed to make sure the bowel hasn't slipped into an ileus. And if you pull back more than 200 cc of aspirate, stop the feed immediately. That's how you prevent deadly pulmonary aspiration. Section 3. Total parenteral nutrition, or TPN, feeding through the veins. So what if the gut is just completely out of commission? You only bypass the gut for very strict indications. We're talking about a prolonged paralytic ileus that lasts more than 72 hours. Or short bowel syndrome, especially in those net secretors who have less than 100 centimeters of jejunum left and literally can't even absorb basic water and sodium. Other absolute indications: high output fecal fistulas draining more than 500 cc's a day, and the very initial phase of acute severe pancreatitis. Though, quick side note, even with pancreatitis, we switch back to the gut the second it's safely possible to help drop mortality rates. 2,000, that's the magic number. 2,000 kilocalories packed into a standard daily TPN bag. This thick, milky solution is typically split into an exact, carefully calculated ratio: 50% carbs, 30% fat, and 20% protein. Now, because TPN is incredibly concentrated and sugary, you can't just run it through a standard peripheral IV. It'll cause severe thrombophlebitis. You need a central mine. The subclavian vein is the gold standard here because it has an exceptionally low infection rate. But it does carry the highest risk of accidentally causing a pneumothorax during insertion, so you absolutely must check a post-insertion chest x-ray. The internal jugular vein is the most common line overall, mainly because it's the easiest to pop in under ultrasound. What about the femoral vein? We aggressively avoid it. The infection and thrombosis rates are just way too high. If you need a peripheral option for a few weeks of feeding, a PICC line is fantastic. Its tip still rests safely in the central circulation, right above the right atrium.
Section 4. Navigating TPN complications, the risks of artificial feeding. Which brings us to a massive life-or-death question that you're going to hear on the wards and exams all the time. What deadly cascade happens if you give large quantities of TPN to a starving, chronically malnourished patient way too quickly?
It triggers refeeding syndrome. The starving patient's body has been in a catabolic state, basically breaking down its own buildings just to survive. When you suddenly flub them with TPN, the body violently shifts into an anabolic building state. This sudden massive spike in glucose causes insulin to surge. That insulin immediately shoves potassium, phosphate, and magnesium straight out of the bloodstream and into the newly building cells. The result? Rapid hypokalemia, hypophosphatemia, and hypomagnesemia. This leads directly to fatal arrhythmias and congestive heart failure. You prevent this by feeding very gradually and strictly monitoring those electrolytes. Beyond refeeding syndrome, you have to stay incredibly vigilant. Hypoglycemia is remarkably the most common overall complication of TPN. Let that sink in. You also got to watch for catheter-related sepsis. If a TPN patient spikes a fever, suspect the line immediately. Take cultures from it, and if you have to, pull the whole line and culture the tip. Also, keep an eye on the scale. Families often think TPN will make the patient pack on muscle overnight, but actual real weight gain doesn't start until day 5 or 7. So if you see a sudden weight gain of more than 1 kilo per day, that's not muscle, that's fluid overload. Stop it immediately. Finally, watch for elevated bilirubin, which signals cholestasis, and be ready to supplement zinc because that's the most common micronutrient deficiency here. Section 5. Post-operative fluid management. Goal-directed hydration on the wards. All right, for our final stage, we're shifting gears from calories to hydration. Fluid management must be entirely goal-directed. You never want to just blindly hang bags of fluid. First, calculate your patient's baseline insensible losses. That's roughly 30 to 40 mils per kilo. Then, you meticulously replace their exact outgoing losses. If they have a Ryle's tube draining gastric fluid, replace it cc for cc with normal saline plus potassium. If they have abdominal surgical drains, replace that volume with Ringer's lactate. And replace their urine output with normal saline or dextrose normal saline. It's like a giant puzzle, and every piece needs an exact match. This table, right here, absolute lifesaver for your exams. Notice how Hartmann's, which you probably know better as Ringer's lactate, is the only fluid here that contains lactate and calcium. That makes it a beautifully balanced choice for replacing those complex abdominal drainage losses we just talked about. Meanwhile, normal saline just gives you a heavy 154 millimoles of sodium and chloride.
But you've got to remember the golden rule of post-op fluids, the day 0 rule. Never, ever administer supplemental potassium on the actual day of surgery. Why? Because the sheer trauma of cutting through surgical tissue physically destroys cells, which naturally releases their intracellular potassium straight into the bloodstream. So the patient's potassium will inherently be elevated on day 0. Just wait until the next day to start any potassium replacement. Oh, and totally restrict it if they happen to be in renal failure.